This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, and thank you for joining us today for our HealthyU webinar on osteoporosis. At any time during the presentation, feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous, and today's presenter is Dr. Etzas Ahmed. Dr. Ahmed has been practicing rheumatologist for 25 years. He is certified by the American Boards of Internal Medicine and Rheumatology and is a member of the American College of Physicians and the American College of Rheumatology. His clinical focus includes the diagnosis and management of autoimmune and inflammatory disorders, non-surgical treatment of joint pain, and the management of osteoporosis. He also enjoys graduate medical education and teaching students and medical residents. Dr. Ahmed?
Hello. So good afternoon and welcome everyone to the HealthyU webinar on osteoporosis. The word osteoporosis is from the Greek terms for porous bones. It is a systemic skeletal disorder characterized by low bone mass, microarchitectural deterioration of bone tissue leading to bone fragility, and consequent increase in fracture risk. Bones that commonly break include the vertebrae in the spine, the bones of the forearm, and the hip. Fractures in the spine can lead to a curved back or kyphosis, as seen in this picture. Osteoporosis results in 1.5 million fractures per year in the United States, with the vast majority occurring in postmenopausal women. Next slide, please. Osteoporosis is defined in terms of how dense a person's bones are. Bone density peaks at about 30 years of age and then slowly declines over time, as shown in the graph on this slide. The most important risk factors for osteoporosis are advanced age in both men and women and female sex. Estrogen deficiency following menopause or surgical removal of the ovaries is correlated with a rapid reduction in bone mineral density. While in men, a decrease in testosterone levels has a comparable but less pronounced effect. While osteoporosis occurs in people from all ethnic groups, European or Asian ancestry increases the predisposition. Those with a family history of fracture or osteoporosis are at an increased risk. At least 30 genes are associated with the development of osteoporosis. Those who have already had a fracture are at least twice as likely to have another fracture compared to someone of the same age and sex. Many studies have associated smoking with decreased bone health. Tobacco smoking inhibits the activity of osteoblasts, which are bone-forming cells, and is an independent risk factor for osteoporosis. Smoking also results in increased breakdown of estrogen, lower body weight, and earlier menopause, all of which contribute to lower bone mineral density. Certain medications have been associated with an increase in osteoporosis risk. These include glucocorticoids or steroids, certain anti-epilepsy drugs like phenytoin and barbiturates, proton pump inhibitors for stomach acidity, such as omeprazole and lansoprazole, depo-progesterone injections for birth control, aromatase inhibitors such as anastrozole used in breast cancer treatment, and certain diabetes medications such as rosiglitazone. Many diseases and disorders have been associated with osteoporosis. These include untreated hyperthyroidism, which is overactivity of the thyroid gland, Cushing's syndrome, which is overactivity of the adrenal glands that produce excessive amounts of natural steroids in the body, prolonged immobilization, vitamin D deficiency, gastric bypass surgery, which can lead to decreased absorption of calcium and vitamin D, hyperparathyroidism, which is overactivity of the parathyroid glands that regulate calcium balance, inflammatory bowel and chronic kidney disease, and certain autoimmune diseases such as rheumatoid arthritis and systemic lupus. Next slide, please. Osteoporosis is a silent disease. The only time symptoms occur is when a patient suffers a broken bone. Osteoporotic fractures occur in situations where healthy bones would not break. They are therefore regarded as fragility fractures. A fragility fracture is defined as a broken bone due to a fall from a standing height. Some patients have silent fractures which cause no symptoms but are detected incidentally during x-rays performed for other reasons. Acute and chronic pain in the elderly is often attributed to fractures from osteoporosis and can lead to disability and early mortality. The symptoms of a vertebral collapse or compression fracture shown in this image are sudden back pain, often with a radicular pattern, which is shooting pain due to nerve root compression, and rarely with spinal cord compression or cauda equina syndrome. Fractures of the long bones acutely impair mobility and may require surgery. Hip fracture in particular requires prompt surgery as serious risks are associated with it, such as deep vein thrombosis, bed sores, and pulmonary embolism, leading to an increased risk of death. There is an increased risk of falls associated with aging. Part of the fall risk is because of impaired eyesight due to many causes, such as glaucoma and macular degeneration. Balance and movement disorders like Parkinson's disease, dementia, and syncope or collapse due to loss of consciousness related to an irregular heartbeat or cardiac arrhythmia. Next slide, please. Since osteoporosis is a silent disease, diagnosis requires screening tests similar to doing mammograms for detecting breast cancer. Those who should be screened include women who have had menopause either naturally or through surgical removal of the ovaries, men and women with a history of fragility fracture, and those on certain drugs or with medical conditions outlined in a previous slide. Dual energy X-ray absorptiometry, or DEXA, is a means of measuring bone mineral density using spectral imaging. Two X-ray beams with different energy levels are aimed at the patient's bones. When soft tissue absorption is subtracted out, the bone mineral density, or BMD, can be determined from the absorption of each beam by bone. While there are other methods for detecting osteoporosis, DEXA scan is the most widely used and most thoroughly studied technology. The results of a DEXA scan are reported as T-scores and Z-scores. The T-score is the patient's bone density compared to the average bone density in a control sample of people of a similar age. And the Z-score is the patient's bone density compared to a sample of healthy young adults. According to the World Health Organization criteria, a T-score of -1.5 or less is considered normal. Between -1.5 to -2.4 is osteopenia, and -2.5 or higher is classified as osteoporosis. Medications to prevent fractures are recommended for patients with a total T-score of -2.5 or higher. Fracture risk assessment, or FRAX, is a clinical tool used for patients whose bone density in the neck of the femur is -1.5 or higher, but whose overall bone density is below the range of osteoporosis. The FRAX calculation is reported as a 10-year probability of fracture. Medications for fracture prevention are recommended in those with a 10-year probability of major osteoporotic fracture at 20% or higher, or hip fracture at 3% or higher. Next slide, please. Resistance and weight-bearing exercise can increase muscle mass and bone density. Longitudinal studies have shown beneficial effects on skeletal microarchitecture in association with some form of regular physical activity. Fractures result from falls, and the number of falls and the proportion of falls that result in fractures increases with age. Exercise and balance programs such as yoga and Tai Chi may result in improved balance and an increase in muscle tone, and may secondarily reduce the risk of falls among some elderly persons. Besides exercise, assessment of the home for hazards such as loose wires or throw rugs on the ground and slippery surfaces in the bathrooms, withdrawal of psychotropic medications when possible, and the use of a multidisciplinary program to assess risk factors are prudent strategies for potentially reducing the risk of falls. Other preventive measures include stopping cigarette smoking, which is linked to reduced bone density, and excess alcohol intake, which can increase the risk of falls. Analyses of several large trials of both calcium and vitamin D supplementation have shown a small reduction in fracture risk, particularly among the institutionalized elderly or those with a low intake of calcium or vitamin D. However, vitamin D alone or calcium supplementation alone has not been shown to reduce the risk of fractures or increase bone density. Standard recommendations for most postmenopausal women with osteoporosis support a total calcium daily intake of 1,000 to 1,500 milligrams per day, either through diet or supplements or both, and a total vitamin D intake of 600 to 800 units daily. Next slide. Before we move on to the medications used for osteoporosis, I would like to review a couple of questions that frequently come up during treatment discussions with patients. The relative importance of the two rare adverse effects, including atypical fractures and osteonecrosis of the jaw, or ONJ, versus the benefits of osteoporosis therapy creates uncertainty and controversy in the minds of patients. The concerns of many people regarding these potential adverse effects with certain osteoporosis medications have increasingly become a substantial barrier to treatment. Osteonecrosis of the jaw is a complication that can occur in patients receiving certain osteoporosis medications who undergo dental surgery, such as root canal, dental implants, or tooth extractions. It causes pain and swelling of the jaw, and in severe cases may require surgery to remove dead bone from the jaw. I want to be very clear that this complication never occurs as a result of routine dental care, including cleaning and scaling or placement of dental caps. The incidence of osteonecrosis of the jaw is very low, estimated at less than 1 case per 10,000 patients receiving osteoporosis therapy. The incidence, however, is much higher among patients with cancer who are taking higher doses of bisphosphonates or another drug called denosumab for treatment of cancer in the bones, and are often receiving high doses of steroids and chemotherapy for cancer, which can independently increase the risk of ONJ. In order to reduce the risk of ONJ, I advise my patients to stop their osteoporosis treatment 3 months prior and resume 1 month following any elective dental surgery. Atypical fractures of the thigh bone or femur have paradoxically been observed in rare instances in women using certain osteoporosis medications, even though these drugs are supposed to prevent fractures. Numerous clinical studies have examined the relationship between atypical femoral fractures and osteoporosis treatment. In all the studies, the incidence of these fractures is low, ranging from approximately 1 in 10,000 to 5 in 10,000 among patients on osteoporosis medications. Several, but not all, studies have suggested an increase in risk with more than 5 years of treatment with bisphosphonates, which are a class of osteoporosis medications. My own practice, therefore, is to limit therapy with bisphosphonates to a period of 3 to 5 years, followed by a treatment-free interval or drug holiday, depending on the medication being used and the patient's clinical circumstances. Let us now move on to a review of medications for osteoporosis in the next slide. This table shows the medications approved by the Food and Drug Administration for treatment of osteoporosis. A class of drugs known as bisphosphonates has a proven track record and a long-established role in the prevention and treatment of osteoporosis. Most bisphosphonates are now available as generics, and due to their effectiveness and low cost, these are my preferred medications for initial treatment of osteoporosis. The first drug is called alendronate with the brand name of Fosamax. It is given orally at a dose of 35 to 70 milligrams once a week. It is effective in reducing the risk of vertebral, non-vertebral, and hip fractures. Like other oral bisphosphonates, it is taken in the morning on an empty stomach with a full glass of water, and the patient should wait at least 30 minutes before eating, taking any other medications, or lying down. Heartburn or irritation of the esophagus is a common side effect, but can be minimized by taking the medication as instructed. Some patients can experience joint aches and pains. Rare side effects include ONJ and atypical fracture of the femur, as discussed previously. Risedronate or Actonel is an oral bisphosphonate that is similar in all respects to alendronate, except that it is given once a month instead of once a week. Ibandronate or Boniva is also similar, except that it has not been shown to reduce the risk of hip fractures. Therefore, I no longer prescribe it to my patients. Zoledronic acid or Reclast is an intravenous bisphosphonate that is typically given once a year for 3 years to patients who cannot tolerate the oral formulations. It does not cause heartburn since it is given through an IV. Patients sometimes experience temporary pain in the joints and muscles, which typically resolves within 2 to 3 days after treatment. Bisphosphonates should be used carefully in patients with kidney disease and are best avoided in people who have very low kidney function or kidney failure. Denosumab or Prolia is an injectable biologic medication that is administered every 6 months. It is effective in reducing the risk of vertebral, non-vertebral, and hip fractures, and like the bisphosphonates, it can cause rare side effects of osteonecrosis of the jaw and atypical femoral fractures. Unlike the bisphosphonates, it can be given indefinitely. One of its side effects is lowering the immune system and an increased risk of infection, particularly skin infections. It is approved for treatment but not prevention of osteoporosis and costs around $1,200 for a single dose as opposed to around $6 for a tablet of alendronate. Teriparatide, which goes by the brand names Forteo and Tymlos, is a derivative of parathyroid hormone which plays a natural role regulating calcium balance and bone health in the body. It is an anabolic agent, which means that it works by promoting the formation of new bone as opposed to the other medications, which are anti-resorptive agents that work by slowing down the absorption of pre-existing bone. It is given as a daily injection. Common side effects include muscle cramps and nausea. It can lower your calcium level, which therefore needs to be monitored regularly during treatment. A rare side effect, mostly seen in laboratory animals, is a risk of osteosarcoma, which is a type of bone cancer. Therefore, treatment with Forteo is limited to a period of 2 years over a lifetime, and it should not be prescribed to patients who have received radiation therapy for cancer. It is effective in reducing the risk of vertebral and non-vertebral fractures. However, no data are available to show its effectiveness in reducing the risk of hip fracture. The cost for 1 month of treatment is around $560. Calcitonin is another natural hormone in the body that regulates calcium balance. It is available in an injectable form and also as a nasal spray, which is approved for treatment but not prevention of osteoporosis. The main side effect is nasal irritation or congestion. It has not been shown to reduce the risk of hip fractures. Raloxifene or Evista is a selective estrogen receptor modulator, or SERM, which works by modifying the action of natural estrogen in the body and is therefore reserved for females only. It is taken orally once a day and is approved for prevention and treatment of osteoporosis. It has not been shown to reduce the risk of hip fracture. The main side effects include a risk of blood clots and sometimes hot flashes, leg cramps, and nausea. Interestingly, it has also been shown to reduce the risk of certain types of breast cancer and therefore could be an option for some breast cancer survivors. Estrogens used to be prescribed to women widely in the past for osteoporosis and many other indications. However, following a landmark clinical trial called the Women's Health Study in 2003, it was shown that estrogen supplements can increase the risk of breast cancer, stroke, and heart attacks. Therefore, their use in osteoporosis has been largely abandoned and is currently limited to management of symptoms such as intolerable postmenopausal hot flashes or vaginal dryness. Another drug not shown in this table was approved in 2019 under the brand name of Evenity and generically known as romosozumab. Like Prolia, it is a biologic monoclonal antibody which is given as a monthly injection. It works by inhibiting the action of sclerostin, which is a protein regulator of bone metabolism. Like teriparatide, it is an anabolic agent that works by promoting formation of new bone. It loses its effectiveness with prolonged use, therefore treatment is limited to 12 months. It has been shown to reduce the risk of vertebral and non-vertebral fractures, but no data are available to show a reduction in the risk of hip fracture. The cost is $1,800 per dose, and common side effects include joint and muscle pain. There is some concern that it may be associated with an increased risk of strokes and heart attacks and should therefore be used cautiously in patients who have a history or risk factors for cardiovascular disease. I personally have not had an occasion so far to prescribe this drug to any of my patients. Next slide, please. Having reviewed the medications, let us now see who should receive them. Recommendations for medical treatment of osteoporosis are outlined in this slide. These recommendations were published in 2016 in the New England Journal of Medicine and refer to postmenopausal females, but are also applicable to other groups of at-risk patients, including males. In the US, most practitioners follow the guidelines from the National Osteoporosis Foundation. Eligible patients are those with a previous hip or vertebral fracture, a T-score of -2.5 or less at the hip, lumbar spine, or femoral neck, or a T-score between -1 and -2.5 with a 10-year probability of hip fracture at 3% and major osteoporotic fracture at 20% or higher. Non-pharmacologic approaches, as previously outlined, include adequate daily intake of calcium and vitamin D, regular weight-bearing exercise, fall prevention strategies, muscle strengthening, and avoidance of smoking and excessive alcohol intake. Pharmacologic approaches include the anti-resorptive and anabolic agents that we saw in the previous slide. Next slide. So in conclusion, osteoporosis is a silent disease that does not cause any symptoms until a fracture occurs. Therefore, patients who are at risk need to be identified and screened through bone density tests or DEXA scan. Osteoporosis is a common disorder that is associated with an increased risk of disability, chronic pain, and premature death due to complications of fragility fractures, particularly hip fracture. Preventive strategies and prescription medications, when appropriate, are effective in reducing the risk of fractures, and the benefits far outweigh any side effects of treatment in most cases. That concludes the webinar, and if there are any questions, I'll be happy to answer.
Thank you, Dr. Ahmed. If anyone has questions, I know there are a few already I can see. You can enter them in the Q&A feature at the bottom of your screen. All of our questions are anonymous, so they protect your privacy. And if we do not get to your question before our time is up, you can also email it to us at matherhospital@northwell.edu, and we will pass any questions we don't get to along to Dr. Ahmed and get back to you. So let me just pull up the questions we have. Can you please discuss the progression of osteopenia to osteoporosis?
Osteopenia is a milder degree of bone thinning. Osteoporosis is a more severe degree of bone thinning. So that is the difference between the two conditions. And both can be defined based on the T-scores that we mentioned in one of the previous slides. So if the T-score is between -1.5 to -2.4, we label that as osteopenia. And if it is -2.5 or higher, then the label is osteoporosis. The rate at which osteopenia progresses to osteoporosis is variable based on each patient's circumstances, their heredity, their use of certain medications, smoking, etc. So it is not uniform for all patients, but on average, there is about a 10% decline in bone density each year after menopause. And the management of osteopenia is to, first of all, assess a patient's fracture risk by performing the FRAX calculation if their T-score is -1.5 or higher in the neck of the femur. That gives us the 10-year probability of a fracture risk. And if the risk of a major osteoporotic fracture is less than 20%, and the risk of a hip fracture is less than 3%, those patients are monitored through serial bone density tests at a given interval, which is typically every 2 to 3 years. On the other hand, if a patient has osteopenia and their 10-year probability of a major osteoporotic fracture is 20% or higher, and a hip fracture is 3% or higher, those patients, it is recommended to start medications for prevention and treatment of osteoporosis.
Next question was, will this webinar be recorded so you can watch it later? Yes, we are recording this, and we typically post our recorded webinars within 2 weeks, and we can share them with anybody who would like to see them or share them with their family or friends. The next question, does removing ovaries have an increased risk to osteoporosis?
Yes, certainly. Menopause, either occurring naturally or through surgical removal of the ovaries, confers a risk for osteoporosis. Therefore, patients who are in such situations should be screened for osteoporosis. The typical recommendation is people who are 2 years or more out of their menopause should be screened. So between 2 years or any time later on after surgical removal of the ovaries would be a good time for a patient to start initial screening for osteoporosis.
Next question is, I've been on Nexium for GERD. Can I assume I'm at higher risk?
There are some observational studies that have shown an association between the use of omeprazole and other what are called proton pump inhibitors and thinning of the bones or osteoporosis. Whether that translates into an increased risk of fracture is so far unclear. So in most cases, if a patient is deriving benefit from treatment for GERD with omeprazole or drugs like omeprazole, it is not necessary to discontinue such treatment, even though they might have osteopenia. There may be some rare instances where a patient is being treated for osteoporosis and they sustain fractures or the treatment is not increasing their bone density, Only in such cases, it may be reasonable to consider discontinuation of treatment for GERD. But for the vast majority of patients, even though there is this association between osteopenia and the use of omeprazole or drugs like it, it doesn't translate into a clinically harmful effect on bones.
I can't tolerate Prolia or any meds. What else can I take to treat my osteoporosis besides taking calcium?
One important treatment is regular weight-bearing exercise, which could be something as simple as a half-hour to an hour walk each day. For the upper extremities, some moderate weightlifting, such as lifting 2 to 5 pound dumbbells each day. Calcium and vitamin D intake, preferably through diet, like having more milk and cheese and dairy products. Those are measures that you can undertake to reduce the risk of a fracture. Reducing your risk of falls is important. So if a person has poor eyesight, for example, or poor balance, then exercises or physical therapy to improve balance and muscle strength, using eyeglasses to improve the vision, having appropriate footwear with slip-resistant shoes, particularly in the winter time when conditions are icy, having slip-resistant mats in the bathroom, adequate lighting inside the house, getting your balance and your bearings, turning on the light before you get up at night to go to the bathroom. Those are some things that are non-medication based that can reduce the risk of a fracture. There are some studies that also they have been done primarily in nursing home patients, and I don't know if that's a situation applicable to the questioner. So particularly for very frail elderly patients, the use of hip protectors is also shown to be, in some studies, as effective as taking medications. And hip protectors are these foam pads that are placed on either side, over each hip, and they can be bought online, and they seem to be effective in reducing the risk of a hip fracture as well.
Is there any connection between osteoporosis and taking metformin for type 2 diabetes?
There are no conclusive studies that show any such connection. The one class of diabetes medicine includes a drug called rosiglitazone, which does seem to have a relationship with osteoporosis.
You covered some of this already when you answered a previous question, but just in case you'd like to add more, what specific physical activity do you recommend, and is walking sufficient exercise?
Walking is very good and sufficient exercise. It strengthens the bones in the hip and in the spine. And then it's usually a good idea to incorporate some upper extremity exercises with some small weights because that strengthens the long bones in the arm and the forearm and reduces the risk of fractures in those areas. For people who have arthritis, for example, and they cannot walk, riding a stationary bike might be an option. And then for people who are homebound or who are very frail, just some range of motion exercises, particularly Tai Chi, has been shown to have a beneficial effect on bone density.
I have osteoporosis of the hip and yet was prescribed Boniva 2 years ago by my GP, which I have taken. Should I change, and which doctor knows most about this? I am a healthy 7-year-old woman who exercises daily, eats well, and has no other risk factors.
So each patient's treatment is individual and it's based on their unique circumstances. And the purpose of this webinar is not to provide specific therapeutic recommendations for a particular patient, but speaking generally, Boniva is approved and available as a therapy for prevention and treatment of osteoporosis. My own preference is not to use it because there are two other agents, alendronate, which is Fosamax, and risedronate, which is Actonel, which have been shown to be effective in reducing the risk of a hip fracture, whereas that data is lacking for Boniva. So in answer to your question, you may want to discuss this with the doctor who's prescribing a Boniva and ask, whether they think it would be appropriate to switch the Boniva to either alendronate or risedronate due to their greater effectiveness in preventing hip fractures as compared to Boniva, and see what your doctor recommends for you.
After 3 years of reclassed, will there be other treatments?
So the duration of therapy with reclassed is limited to 3 years, and the reason for that is a concern that therapy beyond 3 years might increase the risk of these rare complications of atypical femoral fracture or osteonecrosis of the jaw. The effect of reclassed after the last injection, the duration of its effect is unknown, but it probably is a year or two at least. So my approach is, once a patient has done 3 years of treatment, is to repeat a bone density test a year or two after their last dose. If the bone density is adequate and the fracture risk is low, then no other change is necessary. And for the time period between the last dose of the reclassed and the follow-up bone density, the treatment that's recommended is preventive treatment, which is based on non-medication approaches that we had discussed previously, including adequate calcium and vitamin D intake and regular weight-bearing exercise.
How often should I get a DEXA test?
The initial test for women who are 65 or older, or women who are 2 years or more beyond their menopause at a younger age, that's when the initial test should be done. Afterwards, if the initial bone density test is normal and the fracture risk is low, it can be repeated every 2 to 3 years. The frequency can change depending on whether the initial bone density was abnormal or whether the patient has been started on medication, etc. But everything else being okay, the standard screening interval is every 2 to 3 years after the initial scan.
Internal medicine physicians don't suggest testing for bone density. Should I ask my doctor for a DEXA and FRAX?
Certainly you can. If you are in the at-risk group, as we saw in one of the previous slides, if you're a postmenopausal female or a male who has low testosterone, or if you're taking any of the high-risk medications, or if you've had a history of a fragility fracture, those are all reasons to get screened for a bone density test. Generally speaking, most internal medicine doctors do not incorporate management of osteoporosis in their practices. However, a lot of OBGYNs focus on this. So if your primary care doctor, if it is beyond the scope of their practice, then your OBGYN would be another resource because they are very well versed in the management of osteoporosis.
After a course of time loss, sorry if I'm saying that incorrectly, what would you suggest as a follow-up treatment?
After 2 years of teriparatide, which includes the brand names Time-Loss and Forteo, the gains in bone density can dissipate, and therefore so-called consolidation therapy is recommended. And the two options there, one is either a bisphosphonate like alendronate or risedronate, or zoledronic acid, which is reclass. So one of those drugs, or the other option is denosumab or Prolia.
Are you accepting new patients?
Yes, we are.
Does taking a calcium pill provide any protection or effect or not?
So there is some modest benefit showing that there are some improvements in bone density with calcium supplementation. And it has been shown that adequate daily intake of calcium between 1,000 to 1,500 milligrams has a protective effect. It has also been shown that the absorption and the action of calcium is more effective if taken through diet rather than through supplements. So taking it through diet means having more dairy products such as milk and cheese and yogurt, which, for people with high cholesterol can be an issue, but could be overcome by taking low-fat dairy products. Some people are lactose intolerant, and in such cases, taking a tablet form of calcium is also beneficial, as long as it's meeting the goal of 1,000 milligrams to 1,500 milligrams daily. There have been some studies that suggest that over-supplementation with calcium can be a risk for heart disease. So therefore, exceeding more than 1,500 milligrams daily is not a good idea. The other precaution is for people who have kidney stones, in whom calcium in a tablet form with certain types of kidney stones can increase the risk of kidney stones. And for those patients, again, it's better to take supplemental calcium through diet.
Someone just requested that we repeat the email address. If you'd like to send any additional questions or comments, you can email us at natherhospital@northwell.edu. That's Nather Hospital, all spelled out as one word, no caps, at northwell.edu. You covered some of this again, but I'll just ask it in case there's anything else you'd like to add. Do you have any further suggestions on dietary supplementation and healthy diet tips?
A diet that's rich in calcium and vitamin D is a cornerstone of osteoporosis therapy. In terms of supplements, calcium and vitamin D are useful. Magnesium supplements have been promoted, but there isn't any scientific data to show that they're effective in reducing the risk of osteoporosis or fractures. And in terms of a healthy lifestyle, avoiding smoking and excessive alcohol intake are two other things that are helpful in preserving bone density and preventing fractures. Caffeine intake at one point was thought to be a risk factor for osteoporosis. However, it has been subsequently been shown to not be an issue and does not affect bone health adversely.
There's a medication called Algicol on the market that states it can help bone growth. Do you have any opinion on this? Dr. Ahmed, I believe you muted yourself accidentally.
Sorry, can you hear me now?
Yes.
Okay, so Algicol is not a product that I'm familiar with. I'd be happy to look it up and get back to you through email to answer your question.
Thank you. To determine treatment, are individual L1 to L4 scores or average T-scores for L1 to L4 used for the lumbar area?
Yes, so even though the T-scores are reported for each individual vertebra, treatment decisions and estimation of bone density is based on the total of the average of the T-scores of all the vertebra, not based on just the one vertebra.
How much does hereditary factor play into the progression of osteoporosis? I'm 53, 2.5 T-score, mother and grandmother had severe osteoporosis.
So as we saw in one of the previous slides, genes and hereditary do play a significant role in increasing the risk of osteoporosis. And it is one of the risk factors for osteoporosis. Whether it affects your treatment is unclear because the decision when to start treatment with medications is based on your individual history rather than your family history. So particularly if you have already had a fragility fracture, or as in your case, the T-score is minus 2.5 or higher, then regardless of your family history, those criteria would qualify you to receive osteoporosis. However, it is not a hard and fast or concrete recommendation because the decision when and if to start medications for osteoporosis should be made based on a discussion between the doctor and the patient. One other major risk factor for a fracture is age. So even though your T-score is minus 2.5, you're only 55 or 56, and your risk of a fracture is lower at that age as compared to when you would be 65 years or older. And I see this situation amongst my patients as well, who are younger in their 50s, who've never had a fragility fracture, who may have a positive family history and whose T-score is minus 2.5, where I do discuss the option of starting medications, and the decision is based on each individual's preferences. Most people do choose to take treatment to reduce the risk of fracture, but others who are physically otherwise healthy, they're fit, they exercise regularly, choose to forego taking medication. And in that case, we just monitor the bone density periodically and take measures that are not based on medications to reduce the risk of fracture.
Who administers the FRAX test?
The FRAX test is typically reported by the provider who is performing bone density. So in my case, I refer my patients to one of our local radiology facilities, and they report the FRAX calculation in the bone density or DEXA scan report. If the facility does not report a FRAX and the patient falls in the category where we need to calculate a FRAX, it can also be done through an online FRAX calculation tool where you plug in the patient's bone density and other numbers, and it gives you a 10-year probability of fracture.
Can osteoporosis be halted by weight-bearing and weightlifting exercises?
It can certainly be slowed down, but there are no data to show that it can completely be reversed, but certainly the rate at which bone loss occurs can be significantly slowed down by regular weight-bearing exercise.
Is it better to take a natural source of calcium from algae rather than based from limestone? I take New Chapter Bone Strength, which is plant-based.
So there are several preparations of calcium, including calcium carbonate and calcium citrate, and some are derived chemically, and some, as you mentioned, are from algae and plant-based sources. And the point is, as long as the total daily intake is adequate, regardless of the source, then you get equal benefit. So even though the manufacturers of one or the other product may promote it as being superior, scientifically speaking, the effect of the calcium within the body does not seem to be affected by the type of preparation. The only difference, as I mentioned, is taking calcium through dietary sources seems to be more effective than taking it through synthetic supplements, whatever the source may be.
What's the connection between taking Synthroid for hypothyroidism over a period of 20 years? Oh, is there a connection, I'm sorry, between taking Synthroid for hypothyroidism over a period of 20 years?
So that's a good question. And as we saw in the webinar, one of the risk factors for osteoporosis is untreated hyperthyroidism, which is overactivity of the thyroid gland. Now, synthroid is for the opposite problem, which is underactivity of the thyroid gland. And when on synthroid, the goal is to keep the thyroid function within the normal range. And your doctor usually checks your blood tests periodically to measure the levels of the thyroid hormones. And as long as those levels are in the normal range, taking synthroid is not a risk factor for osteoporosis. However, if the dose of synthroid is higher than what's necessary, which can be checked through the blood test, then using it for a prolonged period of times at a higher than necessary dose can increase the risk of osteoporosis.
Does eating a lot of dairy products add to a high PTH number?
So PTH is parathyroid hormone, and dairy product use does not affect that level in patients whose thyroid function, parathyroid function is normal. Some patients can have overactivity of the parathyroid glands, which is PTH, because of a lack of calcium or vitamin D. And in those patients, taking dairy products with calcium and vitamin D can have a beneficial effect because it lowers the PTH number, which is where it should be in the normal range. Having a high PTH number can be an increased risk factor for bone loss and osteoporosis.
What vitamin D level should a person with osteoporosis try to maintain?
So that's again an interesting question. Vitamin D supplementation has been promoted as a prevention for osteoporosis. The normal ranges of vitamin D are between 30 to 100 milligrams per deciliter. And that should be the goal range for people to have their vitamin D between 30 to 100. There are some experts in the field who feel that even a slightly lower level of vitamin D between 25 to 30 is adequate for good bone health. And that may be true. Again, it depends on the patient's circumstances. And a patient who does not have osteoporosis or has never had a fragility fracture um, would probably be okay with a slightly lesser than normal range of vitamin D. On the other hand, a patient who's already had a fragility fracture or who has osteoporosis would be better off with having enough vitamin D to put it in the normal range between 30 to 100.
What daily intake of calcium and vitamin D supplements would you suggest for a patient on Prolia?
It would be the same as any other person with osteoporosis. So the recommended calcium intake in that situation is between 1,000 to 1,500 milligrams, and the vitamin D is between 800 to 1,000 units a day. Some people cannot achieve a normal range of vitamin D with 800 to 1,000 units a day, and in those cases, the dose can be increased up to a maximum of 4,000 milligrams a day of vitamin D.
I have now been re-diagnosed with osteoporosis after a bone density. In 2017, I stopped with Prolia after 2.5 years under a doctor's supervision, and that bone density test showed I went from osteoporosis to osteopenia. I have been taking calcium and D, do weight-bearing exercises, don't smoke. Where do I go from here?
So it depends on your other risk factors. And if you have been diagnosed with osteoporosis, then by definition, it means that you had a T-score of minus 2.5 or higher, either in your spine or in your hip. If you've had a fracture or a broken bone, or if you're a smoker, those are additional risk factors for osteoporosis. If you're 65 or older, those are again risk factors for osteoporosis and a fracture. And based on one or the other or a combination of all those risk factors, if your bone density test is now again showing osteoporosis, it may be appropriate to revisit starting therapy again as you were taking before.
Do you know if Medicare pays for bone density tests every year?
Medicare pays for annual bone density tests only in people who are receiving treatment for osteoporosis. Otherwise, if your bone density was below the range where treatment would be given, Medicare will cover it every 2 to 3 years. The only situation where they will cover annual bone density tests is if you're receiving medications.
What is the best treatment after 2 years of Prolia?
The best treatment, in my opinion, is a bisphosphonate. However, I just want to mention that treatment with Prolia typically is indefinite, as opposed to pretty much all the other medications where there is a time limit. So we have 2 years maximum with Forteo and time loss. We have 3 to 5 years maximum with alendronate or Fosamax and Actonel and Reclast. Prolia, once started, typically is maintained indefinitely, because if you stop treatment, then the gains in bone density and the reduction in fracture risk disappears. So typically, Prolia is continued long-term.
I am currently 9 months into timeless treatment. I know the recommended timeframe for these injections is 18 to 24 months, but do you agree with using Prolia after this treatment as a maintenance program?
Certainly, that is one of the options to preserve the gains in bone density after a course of treatment with time loss. And another option would be a bisphosphonate, assuming that you haven't had one before in the past. So those would be 2 ways of preserving bone density after you finish your treatment with the time loss.
Does having hip surgery help or hinder osteoporosis?
Hip surgery does not have any beneficial or harmful effects on osteoporosis, or let me say no direct harmful effects. The goal after hip surgery should be to start physical therapy and become mobilized as soon as possible, because prolonged bed rest and immobilization indirectly can create osteoporosis in your other bones. But otherwise, having hip surgery does not impact osteoporosis one way or the other.
Do you recommend almond milk as it has 450 milligrams of calcium per serving?
Yes, certainly almond milk and soy milk are preparations which are suitable for patients who cannot use dairy products to achieve enough dietary intake of calcium and vitamin D, because they are fortified with calcium and vitamin D. So if you're dairy intolerant, for example, and you use almond milk with enough calcium and vitamin D, that would be okay.
So we are currently out of time. There are a few questions that we didn't get to. We'll make sure that we send those over to Dr. Ahmed to answer. And again, if there are questions you didn't get to type in or you didn't have answered today, please email them to matherhospital@northwell.edu and we will pass them on so we can get answers for you. Again, once you exit the webinar, you will be redirected to complete a brief survey. If you could complete this survey, your feedback is extremely important to us. It helps us to plan for future webinars. And if you would like to view our HealthyU webinars, we have them recorded for you. They're on our matherhospital.org/HealthyU page. You can go scroll down and see any of our previous webinars and view them there. This one will be posted most likely within a 2 to 3 week time period, so you can see it then. Thank you everyone for joining us. Thank you so much, Dr. Ahmed, for joining us today and for this very informative presentation, and enjoy the rest of your day.
Thank you.